my disclosure is really more about the obsession I have over this, and it's well over 10 years I've been thinking about this. We initially thought this was a periprosthetic stress fracture due to compromised bone from acromion wear, subacromial decompressions, and certainly the deltoid dependence. But we now know that this is multifactorial. It relates to bone quality, the scapular morphology, like the thickness of the I-beam of the scapular spine, implant stresses that we put on there, surgical techniques that we do, and the indications we choose to operate on. The overall incidence sits at about 3.9%. It sees you more than you see it. It's absolutely sure. It is definitely more common in certain populations like inflammatory arthritis or patients with locked anterior shoulder dislocations. About 10 years ago, we came up with this classification that was based on the deltoid origin. The observation that patients with more medial-based fractures had more of their deltoid origin involved and therefore had worse results was the impetus to try to put this together. But Andrew Boltuck, one of my fellows a few years ago, started to recognize clusters, different patterns of clusters that occurred within the type 2 zone. And this paper defined a subclassification of type 2 fractures, with A's being medial at the A's being at the turn of the acromion, B at the glenoid face, and C's a little bit medial to that. And then we did a little bit more refined analysis of where the fractures occur, and we recreated the fracture patterns on a fracture map, and it looked like very clear zones of fractures. So essentially there are 4 clusters of zones. There's the lateral most fractures, those type 1s. There's where the acromion turns, that's the type 2A. Type 2B is a transverse fracture. It happens along the layer of where along the interface of where the glenoid is fixed. And then the type 3, the dreaded base of the acromion fractures, are the worst.